In medical pharmacology, spironolactone is universally classified as a diuretic. Yet, when a patient presents with an acute need to clear fluid, clinicians almost never rely on it for that task. Compared to the aggressive, rapid action of loop diuretics like furosemide, which can offload liters of fluid in hours, spironolactone is remarkably weak and slow. Expecting immediate symptom relief from spironolactone ignores the actual mechanism of the drug. Spironolactone trains rapid fluid dumping for the power of long-term molecular regulation. It achieves this by targeting the mineralocorticoid receptor. Its highest clinical value is acting as a strict aldosterone antagonist. By blocking this specific hormone, the drug halts cardiovascular remodeling and manages severe chronic disease states. Prescribing spironolactone solely for fluid clearance ignores its more significant function as a life-prolonging disease modifier. To understand why it acts so slowly, we have to look at its primary site of action, the principal cells within the distal convoluted tubule and collecting duct. Inside a principal cell, aldosterone docks into a mineralocorticoid receptor. The complex travels to the nucleus, binding DNA to transcribe aldosterone-induced proteins. These form ENaC and sodium-potassium ATPase pumps on the membrane, driving massive sodium retention and pumping potassium out. Spironolactone physically outcompetes aldosterone, occupying the receptor and halting nuclear translocation. The nucleus stops synthesizing new proteins. Existing sodium channels and ATPase pumps slowly degrade. Sodium is blocked, causing diuresis, while potassium and hydrogen secretion halts, retaining them safely. Because it relies on waiting for existing protein channels to physically degrade, the antihypertensive and diuretic effects take days or weeks to reach full potential. Spironolactone alters DNA transcription and protein synthesis. Its power lies in rewriting the cell's underlying behavior rather than just blocking a pre-existing channel. This microscopic cellular blockade translates into systemic changes, particularly in disease states driven by excess, unchecked aldosterone. The first major clinical pillar is stable chronic heart failure with reduced ejection fraction, or HFrEF. In heart failure, high aldosterone drives a destructive process. The hormone signals myocardial fibers to rapidly thicken, stiffen, and intertwine with rigid fibrotic scar tissue. When used alongside other therapies, spironolactone blocks this fibrotic signaling, physically protecting the heart structure. The second pillar is cirrhosis of the liver, complicated by ascites and edema. As the liver fails, it triggers prolonged secondary hyperaldosteronism. The kidneys respond by retaining massive amounts of fluid, which then accumulates in the abdomen. Spironolactone is precisely targeted to neutralize this secondary hyperaldosteronism, allowing the body to slowly and safely drain the ascites. The third application addresses primary hyperaldosteronism, often manifesting as resistant hypertension. The drug serves as a direct chemical countermeasure, treating both the hypertension and the dangerous hypokalemia caused by the excess hormone. In all three of these conditions, spironolactone is prescribed to neutralize the specific aldosterone-driven pathology that is destroying the organs. Because this drug exerts such powerful control over cellular ion exchange, prescribing it safely requires strict clinical protocols. The most dangerous pharmacological interaction is the risk of hyperkalemia, dangerously high levels of potassium in the blood. In the renin-angiotensin-aldosterone system, co-administering spironolactone with ACE inhibitors or ARBs creates a compounding risk. Blocking the pathway upstream and downstream causes a severe potassium bottleneck. Adding potassium supplements or salt substitutes pushes serum potassium directly into the danger zone. Clinicians must also monitor the use of NSAIDs, which can blunt the drug's diuretic effect and risk worsening the patient's overall renal function. Beyond the kidneys, the drug also exhibits significant off-target molecular behavior. The physical structure of spironolactone inadvertently allows it to bind to and block androgen receptors, preventing testosterone from attaching. This off-target block causes gynecomastia, can cause breast tenderness, and triggers menstrual or sexual disturbances. Predicting these side effects requires recognizing the drug's dual ability to block ion channels in the nephron and interfere with systemic steroid receptors. We return to the clinical choice between a rapid loop diuretic and spironolactone. The mechanism is rigid. It promotes sodium and water loss while rigidly conserving potassium at the cellular level. This allows clinicians to safely reduce fluid overload over an extended timeline, avoiding the lethal arrhythmias or sudden electrolyte crashes associated with aggressive fluid dumping. While loop diuretics handle the acute goal of rapid symptom relief, spironolactone is deployed for the long-term goal of cardiovascular protection. Spironolactone secures its place in modern medicine by counteracting maladaptive hormones and rewriting the trajectory of